begin my talk on DSC, DCE, and ASL perfusion weighted imaging for brain tumor imaging. In the first half of the lecture talk, I'll be concentrating on the basic physics of the perfusion MRI. So as you all know, DSC PWI is T2 star based imaging, and the strongly paramagnetic gadolinium induces susceptibility effect on T2 star weighted imaging and causes dark signal intensity on the imaging. So we start with the signal intensity, and which is converted to the change in relaxivity, which is then converted to the concentration of the contrast agent within the tissue and converted to various parameters in the perfusion weighted imaging. So as the first step, as gadolinium arrives in the brain and washes out in the first passage, you can see the transient loss in the signal intensity, starting from the large arteries, parenchyma, and the large intracranial veins. So here's a typical signal intensity time curve as the gadolinium arrives in the brain and washes out in the first passage. So in the first, after you get the signal intensity time curve, it's converted to the change in relaxivity curve, as shown here, or the relative concentration of the contrast agent. And then from the concentration time curve, the area under the concentration curve corresponds to the cerebral blood volume. And you can also get the time to peak from the curve. And going back to the delta or relaxivity time curve, you could get the CBF by applying the deconvolution using the arterial input function. Oh, sorry, apology for the distraction. So from the after you apply the deconvolution using the arterial input function information, you could get the CBF from the curve. And when you divide the CBV by the CBF, you'll get the mean transit time parameter. Next, that was just brief introduction for DSC. And next, moving on to DCE, it's T1 based technique where you also use the strongly paramagnetic gadolinium agent, but this time it causes T1 shortening, as you all know, which induces a high signal intensity on T1 weighted imaging as shown here. So you can see the dramatic contrast between the tumor tissue and the healthy tissue. And from using the DCE, you can derive many quantitative and semi-quantitative parameters as shown in the table. And of those, the three most popular ones are K-trans, VE, and VP. And the K-trans corresponds to volume transfer constant between plasma and extracellular extravascular space. And the VE corresponds to volume of EES per unit volume tissue, whereas the VP corresponds to blood plasma volume. So to get the three parameters, you have to use a specific model. And the most popular model used to derive the parameters is the TK model, where it assumes where it assumes two compartment model, compartments within the model, and it assumes the equilibrium of contrast media between the plasma and EES, as shown here. To get the three parameters, we have the signal intensity, as I mentioned before. So this is the starting point, which is converted to the T1 relaxation time before and after the contrast injection. And the T1 values, relaxation times, are converted to the concentrations, tissue concentrations, and the plasma concentrations, which are then converted to the K-trans, VE, and VP parameters using this complicated equation. So I don't expect anyone to memorize these equations, but just wanted to give you a brief concept of how the signal intensities are converted to the parameters of interest at the end. So what do the parameters actually represent in terms of the tumors? The VP, which is the blood plasma volume per unit volume of tissue, is thought to reflect angiogenesis for tumors, whereas the K-trans and VE, which reflect the volume transfer constant between the plasma and ES, or ES volume per unit volume of tissue, are thought to represent the imaging biomarkers for BBB permeability. And next, moving on to ASL. In ASL, the labeled water molecules reduce the longitudinal magnetizing vector, resulting in the drop in signal intensity. So you have more pronounced reduction of the signal intensity in the regions with higher perfusion, And subtracting the control label image from the control image will give you the CBF map using the equation shown at the bottom. So you have to scan twice, one without any labeling and the other one with the labeling at the level of carotid bulb. So although ASL provides only CBF value in comparison to other two perfusion weighted imaging, which provide many other values, it definitely has some advantages over a more commonly used DSC MRI in routine clinical practice. So going over one by one. First, ASL provides absolute quantification of CBF value and is totally non-invasive. It does not require any contrast agent, which will allow you for repeated measurements in one subject, say, for example, in seizure patients. And it's less sensitive to susceptibility artifacts, and it can be used also outside the brain. So it definitely has some several advantages over the DSC MRI. Now, in the second two-thirds of the talk, I'll be dealing with some clinical applications of the three perfusion weighted imaging in brain tumors. So for before we go into the clinical application of DSC, let's just take a brief look at how blood vessel overgrows in tumor cells. So as the tumor starts growing, showing overgrowth, it'll secrete VEGF, which is a commonly known growth factor, to all of you. And that factor increases blood vessel expression and induces movement of the vessels to the tumor. And the result would be the increased blood supply to the tumors. And the phenomenon would be called angiogenesis, which all of you would be familiar with. And this would result in increased CBV on DSC perfusion weighted imaging. So the characteristic would be used to differentiate typical high-grade gliomas from low-grade gliomas and high-grade gliomas from the other common CNS tumor, primary CNS tumor, lymphoma. So in high-grade gliomas, the increased angiogenesis and dilatation of pre-existing vessels would result in increased cerebral blood volume, as shown in the typical example at the bottom. So there was a typical necrotic mass in left temporal lobe, which had diffusion restriction at the enhancing portion and increased CBV, reflecting the angiogenesis at the enhancing portion of the tumor, which is the most aggressive part of the tumor. So this was a typical example of GBM-IDH wild type at WHO grade 4. In contrast, WHO grade 2 astrocytoma IDH mutant, you'd see some tumor-like features such as some mass effect as shown here. So there's a T2 hyperintense lesion at right frontal lobe with a bit of mass effect, but no definite contrast enhancement, no definite diffusion restriction, and no definite CBV increase. But this was diagnosed as a tumor of this specific pathology. So you can see a dramatic contrast between the low-grade and high-grade gliomas in terms of the CBV map. Here's the other one of here's a typical example of lymphoma case. So you would have a very homogeneously enhancing lesions, multiple lesions around the ventricle, which is a typical location of primary lymphoma. And the lesions show diffusion restriction due to increased cellularity. But unlike the high-grade gliomas, it did not show increased CBV relative to the normal appearing white matters. So this is a typical example of a primary lymphoma showing high cellularity, but no definite angiogenesis as in high-grade gliomas. So CBV is definitely a key player in differentiating high-grade gliomas from lymphoma. And moving on, it could also be used to differentiate radiation change from progressive disease. And here's a brief schematic diagram of how low-grade astrocytomas and grade 4 astrocytoma are treated in the routine clinical practice. And in the first part, in the previous few slides, I've shown you that CBV can be used to differentiate the low-grade from high-grade gliomas. But as you can see in the next half of the schematic diagram, it can also be used to differentiate the radiation change which could occur during the treatment process from progressive disease. So moving on, getting more deeper into the specific type of radiation change. The phenomenon called pseudoprogression occurs in the subacute stage of RT change, and its peak incidence is at 1 to 3 months after CCRT. It more commonly occurs in the tumors with methylated MGMT, and it resolves spontaneously without any change in the current treatment. So here's a typical example. You can see a new enhanced lesion at the right temporal lobe, and with continuation of the existing treatment, it spontaneously disappears, and it was retrospectively diagnosed as pseudoprogression. So at this stage, it's very confusing whether this is a true progression or pseudoprogression. And for that, DSC can also play a role in the differential diagnosis. So here's an example. Before CCRT, just after the surgery, you can see the surgical cavity at right temporal lobe without definite measurable enhancing lesion. But 1 month after the end of CCRT, we saw new enhancing lesions at right temporal lobe, which did not show any significant diffusion restriction or increased CBV relative to the normal appearing white matter. And you can see that the lesions spontaneously resolved 4 months later. So it was compatible with the pseudoprogression, and the CBV map at the time of the appearance of the new enhancing lesions was kind of helpful to differentiate the pseudoprogression from true progression. And in contrast, this case also did not show any measurable enhancing lesion just before the CCRT, but developed new enhancing lesion at the surgical margin. But in this case, had increased CBV and no definite diffusion restriction. But because of this, we were kind of worried this was a worsened feature for the progressive disease. And you can see in the follow-up, there was a growing size of the enhancing lesion, which was compatible with the progressive disease. So again, at this stage where we had the growing or newly appearing enhancing lesion, the CBV map was helpful in differentiating pseudoprogression, which is a form of RT change, from true progressive disease. And just for the RT change, it could also appear at the late stage of the radiation. For some reason, I do not see the part of the slide, but I'll start continuing to see what happens. So anyway, it was also tested in the 50 patients who had new measurable enhancing lesions more than 6 months after the complete response following radiation therapy. And this study analyzed the normalized CBV value and the proportion of dark signal intensity on SWI within the enhancing portion to see how they had how they performed in the differential diagnosis of late stage radiation necrosis and the progressive disease. So the recurrence it turned out that recurrence shows significantly lower hemorrhagic portion and higher mean normalized CBV, or the 90th percentile of the normalized CBV, as compared with the radionecrosis. And the combination of the two resulted in the approximately 82% of accuracy in differentiating the two. So here's a typical example. This grade 3 astrocytoma had new enhancing lesion 14 months after CCRT completion. And this lesion showed minimal hemorrhage in the enhancing portion and increased normalized CBV, 90th percentile of the normalized CBV, with the actual value corresponding to 5.13. And the histological specimen showed just a bit of hemorrhage, not too much. And this case corresponded to the recurrence. In contrast, this one had also new enhancing lesion around the surgical margin 18 months after the completion of CCRT, but had quite a bit of hemorrhage in contrast to the previous one, and elevated normalized 90 percentile of the normalized CBV, but not as much of the previous example, and was shown to have multiple hemorrhages on the specimen, and was confirmed as radionecrosis. So yes, radionecrosis tends to have more hemorrhage and less of the elevated normalized CBV. And moving on, it could also be used to predict the prognosis of the diffuse glioma. And this study evaluated about 200 adult type diffuse glioma grade 4 patients who had undergone the standard treatment, and aimed to develop 2 NNU-net deep learning models for prediction of early local progression in the patients. And one of the model used conventional MRI alone, consisting of FLAIR and contrast-enhanced T1 weight image, and the other one, multiparametric MRI, included DSC perfusion weighted imaging. So here, the schematic diagrams. In the conventional image, we had the FLAIR and the contrast-enhanced T1 weighted image fed to the training model, and the labels were manually drawn within the non-enhancing T2 hyperintense lesion with the reference to the true recurrence at the follow-up MRI. So it was the local progression areas were manually annotated, and these two information was fed into the conventional model, whereas those, in addition to the CBB, were fed to the multiparametric MRI model to see how they differ in their ability to predict the local progression. So here's a typical example where the normalized CBB map information was kind of helpful. And in this example, you see a necrotic enhancing mass and some surrounding non-enhanced T2 hyperintense area. And there was a definite increased normalized CBB in the enhancing portion, but also there was some mildly increased normalized CBB at the non-enhancing T2 hyperintense portion. And the model correctly predicted the area of local progression by a small dotted area, although probably the DICE index was not high because there's an obvious difference in the area predicted by the model on the true area of local progression. But still, you can see where about the tumor show the local progression. And the model actually doubled the sensitivity, but the specificity did not significantly differ between the two models. So we kind of found it helpful to include the CBV in the context. And moving on, DCE could be also used in the clinical context to differentiate high-grade tumors from low-grade tumors or radiation change. And the explanation is given in the slide. So for high-grade tumors, you would have high leaky vessels through angiogenesis, which would show high permeability and lead to high contrast leakage. But in low-grade tumors or radiation change, the degree of angiogenesis would be normal or low, or leading to low permeability and almost no contrast leakage as shown in the slide. So using the characteristics, it was used to predict the grade of the gliomas. So in this first paper, which was published in 2014, it tested the value of the DCE parameters, 3 popular DCE parameters derived from the entire tumor volume in the 28 patients with confirmed gliomas to see how they perform in predicting the grading. And the results show that as you increase the grade, there was a definite increase in the KTRES and VE, the imaging biomarkers for the BBB permeability, and definite increase in the VP, which is the biomarker for angiogenesis. So that kind of makes sense. And here are the other graphs also showing the differentiation between the grades. And in the multivariable logistic regression, the 98th percentile of the K-trans was shown to be the only independent predictor. In the next study, our colleagues studied the value of the DCE in differentiating true progression from pseudo progression at the subacute stage of the treatment. And they've shown that the true progression showed higher K-trans and V values, shown in the bar graphs at the bottom. So again, the K-trans was the most useful independent predictor for differentiating the true from pseudo progression with the AUC value of about 0.8. And here are typical examples of the true progression and pseudo progression. And in the pseudo progression case, where you see the resolution of the enhancing portion at the follow-up, you could see that the graphs were left shifted for all 3 parameters, indicating lower permeability and increased lower angiogenesis for the pseudo progression. And we also looked at the fate of persistent measurable enhancing lesions after the end of the standard treatment for the GBMs. And this is not an infrequent situation where you still have some measurable enhancing lesions even after the standard treatment. And we were curious what how they would behave, and we are curious what role DCE could have in predicting their behavior. So we took the 24 patients with the persistent enhancing lesions after standard treatment and evaluate the 3 popular parameters from DCE MRI, just as in the previous study taken at the different stage of the treatment. And interestingly, we found that the progression group actually had lower values of mean K-trans and VE, and 50% of the K-trans is shown in the graph here. So here are typical examples. In the true progression, you could see the values are left shifted in comparison to the non-progression group, which we speculated that as follows. So the low K-trans and VE reflect low BBB permeability, as I've mentioned in the first part of the lecture. And that has 2 sides. It actually can reflect the less effective temozolomide delivery to tumor cells during the standard treatment, whereas it reflected the less low BBB permeability for pseudo progression in the subacute stage of the treatment. Yes, and moving on. And it can also be used to predict the local site of local recurrence, as in the study with the DSC. So similar study design, we also developed 2 models, one using the conventional MRI imaging alone, whereas the other one incorporated DCE and saw the performance of diagnostic role of the DCE, similar to the DSC studies. And in this example, the necrotic mass showed definite increase in the VE value, but there was no discernible increase in the VE value in the non-enhancing tumor portion with naked eye. But the model correctly predicted the site of local progression at about 1 o'clock direction of the enhancing tumor as shown in this example. This is the follow-up MR to confirm the site of progression. So again, the addition of the VE map doubled the sensitivity in the study. Lastly, touching a little bit on the role of ASL in the differential diagnosis of tumors, it could also show the difference between the GBM. It also reflects the difference in CBF between the GBM and lymphoma. So the top row has necrotic mass with markedly increased CBF, whereas the bottom one has no definite increase or even decreased CBF relative to the normal cortex. And you can guess which one is which. The top one corresponded to the GBM, whereas the second one corresponded to the lymphoma. And using and knowing that the CBF from ASL can also have some diagnostic value, we investigate whether it could be helpful in predicting gene mutation, the popular gene mutation in gliomas, or even survival in the patients. So about 150 GBM patients were taken, and the CBF, preoperative CBF map of the patients were analyzed in terms of the exact normalized CBF value within the contrast enhancing and non-enhancing portions. And the values were correlated with the famous molecular biomarkers and even survivals. And the study showed that the lack of IDH mutation, which we call as IDH wild type, and the lack of promoter methylation of the MGMT were associated with increased CBF at the enhancing portion of the tumor, as shown here. So the perfusion pattern at the contrast enhancing portion and even the non-enhancing portions, they were divided into hypo, iso, and hyperperfusion relative to the normal cortical perfusion. And the hyperperfusion in both the contrast enhancing and non-enhancing portions were associated with the shortest median PFS, as shown in these 2 Kaplan-Meier survival curves. And lastly, it can also be used in other hypervascular tumor, one of meningiomas, which is one of the most popular hypervascular tumor we come across in clinical practice. So we took the 27 patients with meningiomas who had undergone preoperative ASL PWI and DSA, digital subtraction angiography, and correlated the normalized CBF from the ASL with angiographic vascularity, and saw the diagnostic performance of the normalized CBF for for differentiating between high and low vascularity groups, confirmed on DSA. So here are typical examples, and the left one has both of the two examples show well-enhancing convexity meningiomas. But in the first one, we do not see any increased CBF. It was rather decreased relative to the normal cortical perfusion, which corresponded to no or lack of tumor stain on the DSA. But in the second example, you see a markedly increased CBF value, and it corresponded well with a strong tumor stain shown on DSA. So in terms of its diagnostic performance and predicted angiographic vascularity, it had the AUC of approximately 0.88, and even it had a pretty good role in predicting the need for preoperative embolization in these patients. So to conclude, I've just went through very quickly the three most popular perfusion-weighted imaging techniques we use in CNS. The first one was dynamic susceptibility-weighted DSC, contrast-enhanced perfusion-weighted imaging, and the second was DCE, and the third is ASL, relatively newer as compared with the first one, DSC. But all three are relatively commonly used, growing to be commonly used in the tumors, especially the ASL and DCE. And even ASL does not require any contrast agent, so I think it has many potentials in the future use as well. So thank you for your attention, and I'd be glad to answer any questions